Good evening. At the onset, I must thank the organizers for asking me to deliver on this topic to discuss something about statin in Indian setting. And to cut it short, I go straight to the topic. As far as the burden in India is concerned, as per data from ICMR in 2015, the total CHD cases went into lakhs, and out of total CV deaths, nearly 60% were due to deaths due to coronary heart disease. From Mendelian studies, randomization studies of
kind words, I will be speaking on the pulse examination, which is a forgotten art. So, in the pulse examination was since practiced from the ancient times, and a good clinician used to be noted for his ability to detect the pulse and diagnose diseases just by palpating the pulse. The examination of pulse was so emphasized in the 19th century that a device, the sphygmograph, was developed, which used to record the tracing of the pulses and of the patients for diagnosing diseases. Later on, the device fell to disrepute after the development of the Rivarocky cuff for measurement of blood pressure. So, the definition of pulse: it is the expansion and elongation of the arterial wall imparted by a column of blood and is passively produced by the pressure changes during the ventricular systole and diastole. So, there are two types of pulsation: the flow pulsation, that occurs because of the forward flow of the blood traveling through the lumen, and the pressure pulsation, that is the amplitude of the pulse, that's the outward movement of the pulse that is felt by the clinician. The pulse contour is derived in part from a series of frequency waves produced by the antegrade flow as the ventricle ejects, and from the reflections of the arterial impulse that travels from the returning waves fronts from the periphery. The contour depends on the contour as well as the velocity. Both depend on the relative distensibility and the stiffness of the arterial walls. And here we can see that the characteristics of the pulse wave contour, it changes as one travels from the central arteries to the peripheries, from the carotids to the femorals. So, how does the pulse change? So, the upstroke becomes, as we go from the central arteries to the peripheral arteries, the upstroke becomes steeper, the systolic pressure peak becomes high, the systolic upstroke and the time becomes shorter, the ejection time, the systolic pressure, the pulse pressure all increase. You can see here, and the diastolic pressure, the mean pressure decreases. The anacrotic shoulder, we can see here, which is present here, it actually disappears, and the sharp incisura that is present near the central pulses, it is replaced by a smooth and a later dicrotic notch. So, here we can see the tracing of the aortic pulse and peripheral pulse like the femoral pulse. The upstroke rises to a rounded dome here, and I think it doesn't work. And in case of peripheral arteries, the upstroke is steeper. In case of central arteries, the ascending limb has an anacrotic notch which is absent in the femoral artery pulses and tracing. The descending limb has an incisura followed by the dicrotic wave, we can see here, and the femoral pulse, the dicrotic, the incisura is replaced by a dicrotic notch, and that is followed by a dicrotic wave. So, we can see the pulse wave contour tracing from this graph. The initial first upstroke we can see here is the percussion wave, and that is followed, that occurs because of the forward velocity, the peak velocity of the blood ejected during the early systole, and this the kinetic energy is later on stored in the central aorta as a potential energy. This is followed by the anacrotic notch when there is a change in the pulse wave velocity and contour that occurs in the early and mid systole, producing a notch in the slope. Later on, there is a tidal wave which is a later peak, and it occurs in the mid to late part of the systole, and it is produced by the blood moving forward from the central aorta to the periphery with the simultaneous reflection of the pulse waves returning from the upper part of the body. The tidal wave is followed by the dicrotic notch that initiates the diastole and coincides with the aortic leaflet closure. The positive wave that follows the dicrotic notch, sometimes called the dicrotic wave, is most likely represents the reflections of the pressure pulse wave from the arteries in the lower half of the body. The arterial pulse is best described as early, late systolic, and diastolic components. With aging and decreased compliance of the arterial tree, the later portions of the pulse wave becomes accentuated. So where do we look for the pulses? The commonest site is the radial pulse. The others are the carotids, the superficial temporal, especially if there is a history of jaw claudication, the facial artery, the subclavian artery, which is palpated against the first rib, the brachial arteries, the ulnar, the abdominal aorta, the femoral, popliteal, posterior tibial, and the dorsalis pedis. We should note that the posterior tibial artery may be absent in 5% and the dorsalis pedis may be absent in 10% of the cases in normal patients. That may be because of their abnormal courses. However, the loss of this pulse is actually symmetrical, and any asymmetry in the pulses should always be warrant further search for any other pathological condition. Another thing to note is that we should examine both the pulses on both the sides. That is, sometimes if we don't get a pulse in one hand and we don't get a BP in one hand, if the patient is relatively stable, we should always check the pulses in at least the 4 limbs, because many a times we may miss some aortoaortitis or other diseases, and we may erroneously diagnose the patient as having a shock, and we may put the patient on vasopressors. The other thing to remember is that the radial artery may sometimes take an aberrant course just over the styloid process of the radius and just beside the cephalic vein, and that may be a nightmare for the anesthesiologist who may inadvertently cannulate the radial artery there instead of the vein. So all the arterial pulses are palpated against some bony prominences, and we can see from here that the superficial temporal artery is palpated in front of the tragus, the carotids in the medial to the sternomastoids, etc. So the method of the palpation is by the trisection method, with the proximal index finger occluding the artery. The ring finger is used to control the pressure, and the middle finger for palpation of the artery. So palpation of the carotid artery may be done with the index finger and the middle finger or the thumb, and it is palpated just below in the lower part of the neck. That is, the common carotid artery is palpated, and we should always auscultate the carotids before we palpate the carotid arteries, so that there is no chance of embolism. Both the carotids should not be examined simultaneously. So these are the methods for examining the brachial pulse medial to the bicipital tendon and the popliteal artery. The posterior tibial artery is palpated behind the medial malleolus, and the dorsalis pedis against the first base of the first metatarsal bone. Abdominal aorta is palpated just above and to the left of the umbilicus with both the hands, and if the pulsation is felt, we should always look for the expansile nature of the aortic pulsation with both hands, as shown in the second figure. This also gives a rough estimation whether the aorta is also distended or not. Any abdominal aortic pulsation below the umbilicus should always be warrant further search with proper imaging techniques, because the aortic bifurcation usually occurs at the level of the umbilicus, and pulsation below the level of the umbilicus signifies presence of an abdominal aortic aneurysm. So how do we go on with the pulse examination? The rate, the rhythm, the volume, character, the delays, the arterial wall, and palpation of all the peripheral pulses. So the way we see, we actually count the pulse for 15 seconds and multiply by 4. However, if we get an irregularly regular pulse, we should always check the pulse for 1 whole minute. We should check for tachycardia, bradycardia, normal range we all know. And so next we go on to check the rhythm. The rhythm may be regular, or there may be arrhythmias. The arrhythmia may be either a regularly regular pulse, as we see in sinus arrhythmia, pulses bigeminy, alternance, or first and second degree AV block. Irregularly regular pulse may be caused by atrial fibrillation, multifocal atrial tachycardias, or frequent ventricular premature complexes. The ventricular premature complexes, there is a how do you differentiate clinically between ventricular premature complex and the atrial premature complex? Ventricular premature complex, there is a large pause between the following the premature beat because of the compensatory pause. In case of atrial premature complex, the pause is shorter. Atrial fibrillation, there is a irregularity in the rate, rhythm, as well as the volume, and there is a apex to pulse deficit of more than 10 beats per minute. Some authorities consider this as a 6 beats per minute. The pulse deficit may be calculated by a 2 observer or a single observer technique. A 2 observer by simultaneous checking of the pulse rate and the heartbeat, and the single observer by counting the number of pulses, a number of heartbeat that is not transmitted to the radial artery. After we get the pulse, we can examine all the pulses. We can actually tabulate the pulse as being absent, feeble, palpable but diminished, normal, or large volume. Lastly, if we get a low volume pulse, we can auscultate for bruise over the arteries. If there is a systolic bruit, it suggests less than 50% occlusion. 80% occlusion, we get a continuous bruit, and 80 to 100% usually there is no bruit. However, this actually has a very poor correlation with ultrasound findings or Doppler findings. Coming to the pulse volume. The pulse volume may be normal, may be low, that is known as a small weak pulse, the pulsus parvus found in aortic stenosis or congestive heart failure. Pulsus magnus found in aortic regurgitation is a large amplitude high volume pulse, and a hyperkinetic pulse that is found in pregnancy, anemia, thyrotoxicosis, beriberi, and other hyperkinetic states. Coming to the pulses, special pulses, the pulsus parvus et tarus, that is a small volume and delayed peaking pulse. We can see a prominent anacrotic notch here and a delayed peak. And actually, the delayed peak signifies a significant organic stenosis, and this is one of the findings that we can actually differentiate between presence of a systolic murmur in aortic regurgitation, as well as whether the patient is having an organic AS or a functional AS. So in case of a functional aortic stenosis, the peak will be early, whereas in case of an organic AS, the peak becomes delayed. Hypokinetic pulse is a small or diminished pulse. However, in contrast to the pulsus parvus et tarus, there is a normal upstroke, and it is found in low output states, hypotensive states, and there is sometimes in intense vasoconstriction may reduce the pulse amplitude in the face of a normal stroke volume. Hyperkinetic pulse, there is a larger than normal amplitude resulting from an increase in left ventricular ejection, stroke volume, and arterial pressure. The typical high output states like anxiety, anemia, thyrotoxicosis may cause a hyperkinetic pulse, as is VSD and mitral regurgitation. Coming to water hammer pulse, there is a rapid upstroke followed by a rapid descent. We can see from the graph here. The rapid upstroke results from a rapid ejection of the increased stroke volume, and the rapid descent is because of the rapid runoff to the LV, as well as because of reflex vasodilatation and peripheral runoff due to decrease in systemic vascular resistance. So, how do we examine for the water hammer pulse? First we inquire the patient whether the patient is having a any pain in the shoulder or in the elbows. And then we explain the procedures. We hold the radial artery by the ball of the hand, and then we suddenly raise the hand to check for the water hammer pulse. The etiologies may be because of conditions of aortic runoff, like ARPDA, cyanotic congenital heart disease, like truncus, with runoff to the pulmonary artery, or pulmonary atresia with large bronchopulmonary collaterals, or hyperkinetic circulatory states. Coming to the double or twice beating pulse. There are three types of twice beating pulse. One is the bispherians or the bifid pulse present in aortic regurgitations, the spike and dome pattern of the HOCM, and the dicrotic pulse. So the bispherians pulse, the commonest cause are the aortic regurgitation or presence of mild to moderate AS with severe AR. There is a large stroke volume with rapid ejection of, into the LV in the non-compliant arterial tree. The second wave is because is the tidal wave, is the reflected wave from the periphery.
Dr. Ghosh, time is up. Please wind up.
I will, okay, sir.
You conclude. You give your conclusion.
Okay, sir. Okay. So the other is a dicrotic wave. There is one peak is in the systole, and the second peak is in the diastole, mostly found in case of heart failures. So here is a differentiation between the two types of pulses. The other is the pulses alternance, in which there is a alternating high and low volume pulse. And this is also found in patients with who is suffering from a heart failure with severe AR, hypertension, and hypovolemic states. The other is the pulsus paradoxus, in which there is a substantial reduction in the amplitude of the arterial pulse during inspiration and may be confirmed by sphygmomanometry examination. So this is the, in nutshell, the pathogenesis of the pulsus paradoxus, and mostly it is found in some cardiac causes like cardiac tamponade, pulmonary causes like COPD. Sometimes the pulsus paradoxus may be absent when the cardiac tamponade is associated with ASD, VSD, or significant AR. Reverse pulsus paradoxus is an inspiratory increase or an expiratory decrease in the systolic blood pressure, and the causes may be positive pressure ventilation, isorhythmic AV dissociation, or HOCM. The next we should check for is the radial pulse synchronicity, especially, and this may be absent in conditions like tracheostomitis, thoracic outlet syndrome, subclavian steel, and chronic atherosclerosis. The radial femoral delay should be also be checked for, and that is because the radial artery, the pulse transmission time is around 75 milliseconds, and the femoral artery is 70 milliseconds. And this is usually delayed in patients with coarctation of aorta and may be absent in peripheral vascular disease or systemic embolism. The arterial wall should be examined by rolling the vessels and usually in the radial artery against the underlying tissue, and usually done by the 3-finger method. In aortic stenosis, we get a delayed peak, a small volume pulse with a palpable thrill, and a prominent anacrotic notch. In case of aortic regurgitation, we may get a water hammer pulse, pulses bispherians, and locomotor brachialis we can see here. In HOCM, we get a jerky pulse with a brisk upstroke, a bispherian pulse, and a Brockenborough-Brownwell-Morose sign is present. That is a failure to rise in the post-extrasystolic beat following a premature ventricular complex. Thank you, sir, for your patient hearing.
Regarding understanding of the third and the fourth ultrasound, Professor Karmakar, now working in the Department of Medicine, Ajikor Medical College. Professor Karmakar.
And the learned gathering. Good afternoon, everybody. So, I am really thankful to the organizers for giving me this topic to discuss on clinical cardiology, understanding S3 and S4. And I am sure that they have kept this topic for junior doctors, not the senior doctors. Most of the persons present over here, they are seniors. But junior doctors are really lacking because they are busy in presenting their cases. So this would be just recapitulation of our
earlier studies in our studentship. So please excuse me if it is really boring you anyway. So it is really meant for the junior doctors. So heart sounds, we all know that each cardiac cycle gives birth to 4 sounds. Each cardiac cycle is producing 4 sounds rather. First heart sound and second heart sound, they are very healthy. We are very much pleasant to hear that 2 sounds. But whenever S3 and S4, the last 2 sounds, make their appearance, the patient's relative as well as sometimes doctors get panicky. That means we are expecting some pathology in the heart. So we are really not wanting in our lifetime the 3rd and 4th sound of each cardiac cycle. But it will definitely come in our life sometime, in many of our life definitely. So in phonocardiogram is really a very important instrument to find out all these sounds, whether it is audible to us or not. And 3rd and 4th sound is our real concern today, whether it is really panicky or not. So in phonocardiogram, what we see, S1, S2 is being flanked by S4 and S3. As S4 is just coming before S1, that's why it is sometimes called pre-systolic sound or S4 sound. And as it is being produced by the atrial vigorous contraction, that's why it is sometimes also called that it is atrial gallop. And the S3 sound comes after S2, that is in the diastolic period, and early 3rd of the diastole, that's why it is sometimes called protodiastolic gallop. So atrial gallop, protodiastolic gallop. Now, if we hear S3 in young persons, in athletes, during pregnancy, in children, not to be panicky, because it is physiological. Because they are really having compliant heart. They really relaxing their heart, dilating their heart within physiological limit in the early part of the diastole, that is the early rapid filling phase, and that give rise to development of S3. And rest, if you hear randomly whether S3 is present there or not, out of 100 S3s, 40% of S3 will definitely be associated with some pathology of the heart. So we have to be careful whether S3 is there or not, and if it is there, whether it is physiological or not. Now generation, why do S3 occurs? S3 occurs, there are 2 things. One is oscillations of blood back and forth between the walls of the ventricles and is initiated by inrushing blood from atria. And whenever the blood is rushing from left atrium to left ventricle due to gradient, they really does produce tensing of chordae tendineae and thereby giving rise to that soft sound. And occurs just after S2, I have already showed that thing. It's a low frequency sound, its frequency is almost to the tune of 40 cycles per second. And that follows A2, that is the second heart sound aortic component, by 120 to 200 milliseconds. Now, where it is best heard, it is, you all know, it is best heard, could be heard in the supine posture. But if you are thinking that your clinical scenario, S3 is quite likely, if you are not being able to auscultate in supine posture, please try to make the patient on left lateral position and put your stethoscope at apex. After palpation, you try to find out where lies the apex and keep the bell of the stethoscope there at apex. In left ventricular S3, you put bell of the stethoscope at the apex, and in right ventricular S3, you put your bell of the stethoscope in the left 4th intercostal space parasternally. And if you want to make it more audible, more distinct, you ask the patient to hold breath in expiration and hand grip exercise. This will definitely make indistinct S3 more distinct. It is also known as ventricular gallop. How the patient's position is being shown over here. This is the left lateral position. She is palpating, first palpating where lies the apex. Then she is putting her bell of the stethoscope very lightly. Now, in phonocardiogram, all the time you are in each and cardiac cycle, you are getting this sort of S3 marked red, but this is normal. You are not being audible. But I have said that if there is any be a bit pathological due to some other pathological conditions that I will come to later, it will definitely be little bit more, cycles will definitely get increased, its duration get increased, and it is audible over here. So S3 sound is often sign of systolic heart failure, because why we do get panicky, because whenever S3 is present, especially in a patients who are above 40 years of age, we definitely think that patient is definitely having little bit of ejection fraction reduced. It could be the normal limit, because ejection fraction ranges from 55 to 75%, but on serial echocardiography, if it is really getting reduced from 75 to 65 or 60, something like that, and you can hear S3 in that patient, you can be jolly take that conclusion, come to that conclusion that patient within a short time may develop heart failure. So you can give some protective molecules to that patient from the very beginning when patient has already started overt heart failure. This is the S3. Gallop, that typical cadence, the third sound, lap da da, lap da da, lap da da. Now, I have already said why it is because the right panel, this heart is dilated and muscles are thinned out. Whenever in the early diastolic phase, rapid filling is occurring, and that gives rise to development of S3. Now, what could be the most closely mimicking sound in our cardiac auscultation that may mimic or that may confuse whether it is S3 or something else? So you have to go for DD if you are thinking S3, whether you are missing that suspected S3 that could be closely related to split S2 or opening snap. Split S2, A1, pulmonary component and aortic component. If they are really very distinctly split, the second component of that heart sound may mimic S3. Even when we are all aware of opening snap, when opening snap is occurring in a patient who is having mitral stenosis, that may again get confused S3. So how to differentiate these two things? Split, second heart sound, and opening snap is a high pitch sound, and S3 is a low pitch sound. And S3 is always localized. That's why I showed you what would be the typical site for patient while you are auscultating. That would be left lateral position. But S2 or OS, you will be able to hear it in any areas, cardiac auscultatory areas of a patient. And most important part, you try to push the stethoscope bell or diaphragm of the stethoscope, because nowadays stethoscope is available only with one diaphragm. There is no bell and diaphragm. If you push it firmly, it will act like diaphragm. If you keep it lightly, it will act as bell. So if you push it firmly, that suspected S3 or split S2 or OS, whatever it may be, it will be more distinct. So if it is becoming more distinct by pushing the stethoscope on the apex of the heart, it is either split S2 or OS. But if it decreases in its intensity or it disappears totally, it is S3. So this way, the site, whether it is audible in all cardiac areas or with firm pressure through stethoscope, it is disappearing or getting more distinct, that could be important points in differentiating S3 from OS or split S2. So I have already discussed a little bit what could be the causes of S3. One is physiological, I have already said, children, adolescent, young adult, pregnancy, etc. But there are some S3, apart from this physiological, they are distinctly hard, but that may not be that pathological, that may not be related to organic disorders of the heart. that is your anemia, pregnancy, and thyrotoxicosis. Because of the hyperdynamic circulations in these three conditions, we may get distinct S3, but no organic heart disease. Now, some organic heart disease like rheumatic valvular heart disease, like mitral regurgitation, tricuspid regurgitation, or aortic regurgitation, they are very commonly associated with S3 if we really meticulously hear all these patients. But one thing is to be kept in mind. Whenever S3 is there, we definitely think in the line of patient is showing impending heart failure. It is not in the regurgitation valvular heart disease. In MR, AR, and TR, they only indicate that the regurgitation is severe. And you all know that whenever we are coming across multiple valvular heart disease in the form of MS associated with MR or isolated MR showing S3, that means whenever they are having MS MR, MR is definitely predominant. So banking upon only auscultatory finding in MS MR combined heart disease, combined valvular heart disease, if there is S3, it got to be significant MR. It is dominant MR compared to MS. And whenever we are getting in AR, MR, or TR, that means the regurgitation is significant. So hemodynamically significant regurgitation, that doesn't mean that heart is failing. But congenital heart disease, sometimes congenital heart disease, that gives rise to development of S3. What are those? When there is left to right shunt, as in ASD or VSD or PDA. If there is VSD and PDA, there will be left-sided S3, and if there is ASD, there would be right-sided ASD. There would be ASD. And if there is VSD and PDA, there would be left-sided S3. And in ASD, right-sided S3. So what is the significance of getting S3 in these congenital heart disease? That means the LR shunt is significant. So in your clinical diagnosis of all these three congenital heart diseases, you are definitely on bedside trying to evaluate whether it is significant or insignificant. Because significant LR sound, you have to go for operative measures at your earliest possible time. You have to advise at least. So congenital heart disease with S3, I have told the significance of it. Now poor prognosis. Whenever you are getting S3, when the relatives, you have to educate relatives that heart is really failing. Whatever I have discussed right this moment up to the causes of these, up to congenital, valvular regurgitation, hyperdynamic circulation and physiology, you don't have to be that much worried. But when it is associated with ischemic heart disease, when it is associated with dilated cardiomyopathy, you have to be very cautious. You have to treat from the very beginning in an aggressive way so that the heart failure will not aggravate to a great extent. Now coming to the fourth heart sound, the second part of my topic. It is almost similar to that of third heart sound because it is a low pitch sound, because it comes in the diastole, but in the later third of the diastolic period. That's why it is called the pre-systolic sound. And as it is being contributed by the atrial contraction, so it is called atrial dialogue. So whenever patient will have arrhythmia in the form of atrial fibrillation, it is not possible to get S4, you all know. So atria not contracting AF, that means S4 absent, and it occurs just before the first sound, almost 110 milliseconds prior to S1. The lambda, the lambda, the lambda. The first sound is your fourth heart sound. So generations of the fourth heart sound is almost like third heart sound is not well explained, but it is being said that atrial fibrillation, in atrial contraction, whenever blood is being rushed into the left ventricle, that the time when it is decelerating after after hitting the ventricle, that fourth heart sound is being generated. And the causes of fourth heart sound on the left side is hypertension, then comes your aortic stenosis, then hypertrophic cardiomyopathy and ischemic heart disease. Here I like to tell you one thing. I have told you so many S3s where you shouldn't get panicky. But whenever you will find out S4 it is there, it is always pathological. So clinical significance of S4 is much more important compared to S3. So and the right ventricular S4 you will be found here. Left ventricular S4 is systemic hypertension, here it is pulmonary hypertension and pulmonary valvular stenosis, and there left it was aortic stenosis. One thing is to be kept in mind that it is a textbook teaching and we have been taught that way. Whenever you are getting S4 in a patient of aortic stenosis and A wave is prominent in jugular venous, you all the time think of severe significant aortic stenosis. But now it has been little.
Professor Karmakar,
Yes.
this is a pre-lunch session. We are hungry.
2 minutes, sir.
Hello.
One. And S4, I was important sign of diastolic heart failure. It is important sign of diastolic heart failure. So that is in S4, that is the non-compliant cardiac muscles. So it is due to non-compliant cardiac muscles. So patient contraction is okay. So its ejection fraction is all the time preserved. That's why it is being said it's heart failure, but with preserved ejection fraction. So here the S4 presystolic, this is also presystolic, but whenever it is getting loud and higher in its pitch, it is being audible. So S3 ventricular gallop, S4 is atrial gallop. How to differentiate all these things, how it signifies clinically. Occurs in early diastole, I have already said. That's why it is called protodiastolic gallop. And occurs in late diastole, that's why it is called atrial gallop. Occurs during passive left ventricular filling, occurs during active LV filling due to contractions of the atria. May be normal at times, but almost always abnormal. Requires a very compliant left ventricle for production of S3. Requires a non-compliant LV. That is the first and foremost thing for generations of S4. Can be a sign of systolic congestions, that is heart failure with reduced ejection fraction. Can be a sign of diastolic congestive heart failure, that is heart failure with preserved ejection fraction. So my last slide, I definitely acknowledge the help of Dr. Sandeep Ghosh as well as Dr. Athunu Chandra for getting me all these videos and everything, and references are textbook of Barnwell, Haast and Topol. Thank you for your patient hearing.
Dr. Karmakar, many thanks to you for your very elaborate talk on S3 and S4 and its clinical importance. Now, anybody have got any question to ask to Dr. Karmakar? If there is no question, I will request Dr. Arnab Datta. Is he here? Dr. Datta, please.
As Dr. Datta has not prepared, we can, will you spare a few minutes for interactive, any interactive from the postgraduates or regarding the examination of the pulse and this third and fourth sounds? We can discuss that before Arnab becomes ready. Any question from ISO leader?
Cardio friend, about the elderly population, how to examine any peculiarities of pulse exemption elderly patient. Because I deal with elderly, so I think I have a lot of problems sometimes we get, particularly some atherosclerotic. Anything special for elderly?
The elderly patients, they have a very stiff arterial walls, and therefore the thing is that there is a brisk upstroke. So one thing is, if the arteries are very palpable, we can go on to do an oscillus maneuver, and with the and if the oscillus maneuver is positive, then there is chance that these patients may go on to develop pseudo hypertension. That is, you are measuring the blood pressure as high, but actually the intra-arterial pressure is not that high. And therefore, in these cases, if we go on to add antihypertensives, the patient may develop features of postural hypotension and may have falls or syncopal attacks. The second thing is that in aortic stenosis or in these patients, it may be underestimated because of the poor compliance, the upstroke may be brisk and the delayed peak may not be better appreciated. There is a presence of tortuous arteries and other things are also there. There is presence of abdominal aortic aneurysms are more in the elderly and so on.
Thank you.
So at last, and Dr. Datta has come. He will talk on history taking in cardiology.
Yes, that's right. Good afternoon, my teachers, seniors, colleagues, and dear friends. We are talking about a topic of history taking in cardiology in 2019, but I want to remind all my young colleagues, juniors, students, that this topic will never go out of fashion, because however gadget-oriented and technologically developed we become, as doctors and as clinicians, history taking, particularly in a clinical subject like cardiology, will never be out of fashion. When you encounter a huffing and puffing, breathless patient in the ER or in the OPD, it is not many investigations which clinches the diagnosis, but a nice history will give you a clue whether it's actually cardiac asthma or LVF that you are dealing with, or is it a simple exacerbation of COPD or bronchial asthma. So history taking is very important in cardiology because it gives very important clues regarding the final diagnosis. And if you miss that in the first step of your interaction with the patient, you might go completely in the wrong direction and land up in something else where a simple and detailed meticulous history might have saved the day much earlier. I will not go into these things because these are things which we all learned from our third year undergraduate days, that opening the consultation and introducing yourself, taking the confidence of the patient, taking the consent of the patient and making the patient comfortable is the first part of any clinical interaction in any subject of medicine. What is important is the presenting complaint, because that is what has brought the patient to you. And a detailed history of the presenting complaint is absolutely necessary to delineate the natural history of the disease that you are going to deal with. So, when you have the presenting complaints, you need to have a detailed analysis of the presenting complaint, like, tell me more about that. Can you explain what the kind of chest pain was that? And when you are asking for a history of presenting complaints, you always look for these cardinal subsets of things which we studied from our Hutchison's clinical methods many years earlier. For example, onset, duration, severity, course, precipitating and relieving factors, associated features of the presenting complaint, and whether there have been very similar episodes in the past also. Regarding the key cardiovascular symptoms of chest pain, dyspnea, palpitation, syncope, edema, claudication, you need to take a detailed history of each of them. I'll come into them one by one. What is important and different in cardiology from other subspecialties of internal medicine is that the most important history is the history of cardiovascular risk factors, because we know that the commonest cardiovascular condition which brings a patient to you is coronary artery disease. And elicitation of risk factors in these patients of coronary artery disease is of utmost importance. So you need to have a detailed risk factor history in all your cardiology patients. Always establish some basics for all the symptoms which I said earlier from the Hutchinson's clinical methods. For example, for chest pain, you need to have all the details of chest pain, particularly whether it was relieved by sublingual use of glyceryl trinitrate. You rate the severity of chest pain according to your own pain scale. Socrates is very important to remember for our postgraduate students, because it's very easy that with Socrates, pseudonym, you can have all the details of chest pain. For example, its site, onset, character, radiation, association, time course, exacerbating and relieving factors, and severity. The whole thing you get within that pseudonym of Socrates. And you do not miss out anything important when you take the history of chest pain. We know that types of chest pain may be cardiac, non-cardiac. Again, cardiovascular chest pain may be not always be ischemic, because some important conditions like mitral valve prolapse, aortic dissection, hypertrophic cardiomyopathy, valvular conditions like severe aortic stenosis might be associated with non-ischemic chest pain with a history very similar to that of angina due to coronary artery disease. Right. We know the details of angina, how it behaves, how it looks, how to get a detailed history of angina. Very important to remember that in myocardial infarction, that also starts with angina only. Only in the case of myocardial infarction, the chest pain is much more severe, persistent, despite glyceryl trinitrate spray or tablets, and is associated with nausea, sweating, and vomiting. This is the usual presentation of chest pain in a myocardial infarction, the distribution. Substernal, left-sided with radiation to the ulnar side of the arm and fingers. Pericarditis, on the other hand, is relieved slightly by sitting forward. Very difficult to differentiate anginal pain sometimes from diffuse esophageal spasm, which again is central and retrosternal, and again may be relieved by glyceryl trinitrate. But to remember that usually this pain due to esophageal spasm takes a much longer time for relief with nitrates rather than angina, which is relieved in a matter of few minutes. Dissecting aortic aneurysm is again a very close mimic of myocardial infarction and acute coronary syndrome, anginal pain. But to remember that interscapular chest pain of the back is much more common with aortic dissection rather than myocardial infarction. Then we know how to differentiate pleuritic chest pain, musculoskeletal pain. Particularly, we know that TID syndrome is particularly very common in young females. These are the important differentiating points, how you differentiate non-cardiac chest pain from cardiac ischemic pain. The other cardinal symptom of cardiology where you need to take a detailed history is breathlessness, which is usually associated with edema. Dyspnea, again, you classify according to the various classification systems, for example, the NYHA class, the CCS class for angina, and importantly, the specific activity scale, which is a very good numeric scale system to classify your cardiac symptoms. Regarding orthopnea, it's very important to remember that patients usually do not volunteer the symptom of orthopnea. It is only when you ask about them whether they get dyspneic when lying flat, do they say, yes, I do that, and they feel very comfortable to explain that to the physician, the symptom of orthopnea. Paroxysmal nocturnal dyspnea, on the other hand, is also very common and denotes pulmonary edema, raised left ventricular end diastolic pressure, left ventricular failure. Again, the patient doesn't volunteer this information on his or her own. It's only when you ask these patients about specifically about PND do they come out with this nice history of waking up early in the night, spluttering and coughing, sitting up and standing and going to the windows and looking for fresh air in an attempt to regain their normal breathing pattern. So these are the associated symptoms I said. Cough again is common in it's more common with respiratory diseases, less with cardiology, but pulmonary edema may be associated with cough. Ankle edema we know is due to dependency, collection of fluid in the, due to gravity, particularly in the ankles in a standing patient. NYHA class we all know. Regarding palpitations, I said that it's very important to determine whether it's regular or irregular. That's very important to know. Whether it's associated with other symptoms or not. If it's persistent or paroxysmal, because persistent palpitations is usually associated with volume overload conditions like regurgitations of the valves, the left to right shunts in acyanotic congenital heart disease, and some cyanotic congenital heart disease with increased pulmonary blood flow like TAPVC, PAPVC, TGA, etc. On the other hand, the paroxysmal or non-persistent palpitations are usually due to arrhythmias or certain non-cardiac systemic diseases like thyrotoxicosis, hypoglycemia, and even some psychiatric illnesses. Right. Regarding syncope, I again said you divide it into cardiac and non-cardiac syncope. Again, it may be neurally mediated, which is the commonest cause of cardiac syncope, may be associated with arrhythmias in a lesser subset of patients, and more uncommonly with structural abnormalities like LVOT obstruction, either due to HOCM or more commonly severe aortic stenosis. A good history, a good clinical history can always differentiate in 99% of cases between a cardiac syncope and a seizure disorder. For example, a seizure is always associated with certain other things like aura, postictal confusion, convulsive movements, and usually the duration of unconsciousness in a seizure is a little longer than in cardiac syncope, which may be brief for a few seconds or at best a minute. Other cardiovascular symptoms like claudication, particularly arm and leg claudication, which we sometimes miss, has to be elicited, particularly in patients with coronary artery disease, because they often have associated peripheral arterial disease, which they ignore until they are specifically asked for. Rest pain is a very important symptom of peripheral arterial disease, because it might be the harbinger of developing gangrene, which is the next stage after development of rest pain. Fatigue, particularly in heart failure, is an important symptom which we need to elicit, particularly if it was not there earlier. It might also signify certain associated systemic diseases along with cardiological. Other historical parts like obesity, smoking, risk factors, I said, dyslipidemia, diabetes, and family history is important. In cardiology, you also need to have a good past medical history, particularly of previous angioplasties, bypass surgeries, history of rheumatic fever, very important, and acute hospital admissions. Important to remember that certain drugs also are important for causing cardiological diseases. For example, NSAIDs, herbal remedies are an important cause of cardiological diseases. Contraceptive pills, drugs like cocaine are important, again, to have an idea about associated cardiological illnesses. Family history is important because we know that premature coronary artery disease is a very important cause of death in India also. You need to have a good social history regarding smoking, alcohol, recreational drug use, and these are important factors which have a very important bearing on development of coronary artery disease, hypertension, and all other lifestyle diseases which are now an epidemic in India. Regarding congenital heart disease, some important historical aspects which need to be elicited, particularly if the patient is an infant. For example, if there is history of recurrent RTI, like pneumonias, excessive perspiration is a sign of heart failure, and mother may be aware of a vibration or thrill on the chest. This is my last slide. You also need to remember that there are some factors which are important in history taking, which depending on the patient or the physician, you might land up with some problems. For example, command of language of the patient, you are not being able to communicate. Similarly, physician factors like lack of patience, lack of time, and badly structured questions will give you a completely distorted history, which will take you completely in a wrong direction regarding the correct management of your patient. Thank you very much.
Thank you, Dr. Dotto, for your excellent explanation of the importance of the history. Just to summarize, till today, we have to diagnose rheumatic fever based purely on the historical basis. There is the 5 major criteria. Are all the history based on the history, in spite of incorporation of the echo, which still not been incorporated in the major diagnostic criteria of the acute rheumatic fever. Besides, not only clinching the diagnosis, but also assess the functional assessment like NOIHA, Canadian cardiovascular, all based on purely on the historical basis, how far the disease has progressed. This is a very important aspect both from the patient as well as from the physician aspects. Besides, there are certain symptoms which are purely evaluated on the basis of history proper analysis, that is the syncope, simple evaluation of atypical or typical chest pain that can remove majority of the difficulties in diagnosis. So that is the importance of history taking till today. And regarding the pulse examination, it starts from the emergency room by mere presence of pulse that indicates that systolic blood pressure is at least more than 50 millimeter of mercury. And you have rightly described various different types of pulse. So we have to also remember there are some newer, that is in presence of IVP, we can have 2 peaks of the pulse. And regarding the heart sounds, Professor Kormakar has also rightly described, and we have to now know is Doppler correspondence, that when there is the S3, we can have a large E wave. When there is a S4, we have a reduced E wave. So that Doppler correlation and other correlation we can assess from even by the bedside. Thank you very much.
Okay, thank you. This session is closed. The next session will be after lunch, and the speakers are asked to come up on the dais to receive their mementos, please. The speakers, the chairperson, please hand over the mementos to the speakers. Now I would request Dr. Ghosh to hand over the mementos to the chairpersons. Now we will disperse for lunch. After lunch, the session will start sharply at 2 p.m. Thank you.